We are going to start the first session. The first session will be by Dr. Derek Russell. I request Dr. Shukla to please introduce Dr. Derek Russell.
Hello, am I audible? Yeah. Okay, so Dr. Derek is assistant professor, faculty in the University of Alabama. Is also associate scientist, Center for Clinical and Translational Science, General Clinical Research Center, and has received his training from yes, uh, yeah, uh, yeah, and he'll be presenting his experience in U.S. About the COVID-19 and critical care patients. Over to Derek.
Thank you very much, Dr. Shukla. Can everyone see my screen? Okay, I believe I see it up. Hello, I'm really honored to share with you some of our experience in the United States. Let me adjust my screen view here. My topic will be the fundamentals of ARDS management in the ICU as it relates to COVID-19, which I think are, ironically, although this is a novel disease, really a back to basics type lecture. And I hope it's of interest to you, and hope that you find it useful in your clinical practice. This will be a clinical talk. A little bit more about me. I am an assistant professor of medicine in the Division of Pulmonary Allergy and Critical Care Medicine at the University of Alabama at Birmingham in Alabama, which is in the southeast of the United States. I'm also the co-director actually of the program in medical ICU research here, and consequently, the last several months, just as I'm sure many of the audience have been very busy, I've been quite busy focused on research of COVID-19, as essentially all of my clinical and research time is now focused in the ICU space. So the state of Alabama is highlighted in red on the map here. And I'm not sure how familiar you are with the epidemiology of COVID-19 as this disease has spread across the United States, but it initially was centered in the Northeast Eastern Seaboard, particularly in the New York and New Jersey states. But over time, this has washed over the rest of the country, and actually a large epicenter of the outbreak over the summer has been focused around this region where we work. In UAB, if you're not familiar, is one of the largest public hospitals in the United States. So suffice to say that unfortunately we've been quite busy with COVID-19, as I'm sure have many of you. And so our objectives for this lecture will be quite simple. I hope it's informative to compare the overall early United States experience to that of my institution of UAB. I think that informs the rest of the talk, and then we'll discuss some of the lessons that we've learned and perhaps relearned from this pandemic in the United States, which really gets us to our third bullet point of reviewing best practices for management of critical illness in general, but particularly of severe COVID-19. I'm sure many of you are familiar now with the Johns Hopkins website, which tabulates infections and deaths and other metrics of coronavirus infection globally now, and over time it's frequently updated. This is a screenshot of today's view, which shows the United States, where I live and work, unfortunately still leading the world in this dubious metric of global cases and deaths. And unfortunately, India is in second place right now. So obviously a very current topic, and still remains very important in our practice. I think it's most informative to look at the daily cases on the left in yellow and the daily deaths in white on the right of screen over time. And I think you can appreciate that we had a pretty big surge in mid-March through April which, as I've mentioned earlier, was centered initially in the eastern seaboard of the United States. But over time, we actually had a much larger surge in the summer subsequent to that. However, if you look at the deaths, the number of deaths were significantly lower for this larger second surge in the summer than they were in the initial part. And so I have one of the lessons that we've learned, I believe, I think is now reflected in somewhat improved case fatality ratios. We're still not as good as we would like to be, but we have seen some improvements. And I'll argue that one of the reasons for that is a focus on the things that are most important to prioritize. Just of interest, India also, as mentioned, has a lot of cases, and clearly, unfortunately, the Indian subcontinent is not out of the woods either yet. So why was the case fatality ratio so much higher in the early United States surge? I think there are several answers to this question. There definitely are artifactual reasons. So of course, testing has been different over time, and early on, only the sickest could get a test, and so that artificially elevated the case fatality ratio early in the United States surge. But also early on, more elderly, more sick patients tended to be the ones who caught it, whereas later it became younger, relatively healthy patients. However, I think one aspect of this that's perhaps not gotten a lot of press attention, but which I think most of us in the United States now believe to be important, is actually a little bit more complex. So I think early on in March, and I'm not sure if it's the same where you practiced, but where we practiced in the United States, certainly there was a lot of chaos about what drugs to use and how to treat coronavirus or COVID-19. And indeed, many experimental therapies were tried, not in a clinical trial, but just given for purported benefits against this virus on the basis of shaky in vitro or case series type data, but without really any evidence that they were effective, and with some reason to be concerned for side effects or harm from the administration of these drugs. And in fact, you may recall from the earliest literature that was coming out of the United States, many large case series were reported from some excellent, I would say, academic medical centers in the United States. That, but if you look at the details of some of these case series, it appears that almost all patients were given drugs, including antimalarials and other things, which really, I think, in retrospect, didn't ever work. At least there's no good evidence supporting their use, and there is now increasing reason to be concerned about harm. However, I think, if anything, the largest harm from using these drugs is not really in the drug itself, but in the way that it might have distracted us early on when we could have been focusing on the important things that really we knew worked. But instead, we might have been focusing more on these tangential things, which in retrospect, were not known to work then and still are not. The UAB experience, however, has been a little bit different, and I cannot take credit for this at all, but the bottom line is that the people I work with made a very deliberate decision to try not to take hold of anything that is not commonly, is not proven to work, but instead to focus our bandwidth and energy on firming up the fundamentals, the evidence-based treatments that we know are effective for critically ill patients. And COVID-19 patients indeed fit the bill. They really are reflective, despite some controversy early on. They really do reflect, the populations that we're accustomed to serving. And so our outcomes have actually been quite good and considerably better here than they have been at other centers. And so I'll give you a little bit of our early experience data here. I'm showing here a table of all of the patients, the first 77 that we treated in March and April at my center. And I don't know if I mentioned, but Alabama is one of the worst parts of our country in terms of the demographics and the comorbidities of the population, because they just happen to align very much with the populations that are most vulnerable to severe COVID-19. And that's just reflected in our data that we had a very high BMI median and a large number of minorities who are more disproportionately affected by COVID-19. And also the vast majority of our patients had at least one element of the metabolic syndrome as a comorbidity at baseline. However, if you take a look at our outcomes, they really compare very favorably to other outcomes reported at around the same time from other national series and local series in the United States. So shown here is a graph in which on the y-axis are patients. Individual patients make one little block on each line. And then on the x-axis are days from ICU admission. And these are critically ill COVID-19 patients who were admitted to our MICU over time during that initial wave. And as I think you can appreciate, over the first few weeks, the vast majority of them did ultimately achieve a discharge status alive. Unfortunately, some did die, but the rate of death for this critically ill population with a very high comorbidity burden and very vulnerable demographic pattern was much lower than most of the reported series out to 90 days at that time. Now, there have been subsequent improvements in our death rates, as I mentioned earlier, but for March, this was pretty remarkable, and I think it speaks to the value of focusing on fundamentals. However, and I hope this isn't too elementary for this audience, but I thought we might focus on or spend a little time discussing what those fundamentals are. And a good place to start, I think, in terms of what these fundamentals are is an interesting paper that Landoni and colleagues put together in Critical Care Medicine. It's a few years old, but still very much worth the read. And so I would recommend it to you. It's entitled Mortality in Multi-Center Randomized Controlled Trials and Analysis of Trials with Significant Effect. What they did was they screened all of the past literature up to that date for multi-center randomized controlled trials that had a statistically significant effect on mortality. And they also used a global panel of experts to adjudicate the validity of various studies that came out of this screening process. And what they were trying to do was determine how many critical care medicine interventions have been proven really in a rigorous multi-center randomized controlled trial fashion to actually save lives. And you may be surprised to learn how few there are. This is the list they came up with, and this was only a few years ago. It was 15 trials only that really proved mortality benefit in a gold standard multi-center randomized controlled trial fashion. What I want to highlight for you is that several of these trials pertain to the routine care of COVID-19 patients. And so we'll discuss some of these. Mortality is, of course, not the only endpoint that matters. So we'll discuss a couple of other, I think, fundamental things that we focused on at UAB that we felt was a helpful lesson from seeing the pandemic response in New York and other places that didn't fare as well as we did. So I'll try to highlight some of these trials for you in brief. And in the interest of time, we won't dive too deep into any of these, but we'll begin with daily interruption of sedative infusions. This initially was reported in 2000 to reduce the duration of mechanical ventilation by a few days, which is an important endpoint, especially when your hospital may be getting overwhelmed with intubated patients with COVID. And this intervention is simply that once a day, the sedatives are stopped and analgesia is reduced to the minimum necessary for pain control, but no more. If that's nothing, then nothing. But this is done at least once every day. And if sedatives are required to be resumed, rather than going back to the prior dose, you go back to half of the prior dose that was stopped. And in this way, every day, kind of ultimately ensuring that patients are close to the minimum amount of sedatives that are truly required for them. And again, it showed a favorable survival trend that did not meet statistical significance, but this was followed up by Tim Gerard in 2008, who, when they published the combination of this approach with an attempt to liberate from the ventilator, a spontaneous breathing trial. In this paper, it's called SAT rather than intermittent sedation lifting, because he termed it spontaneous awakening trial, SAT. But in this trial, I think it's interesting to note that a number needed to treat of only 7 to save a life for an intubated, sedated patient, for you to simply ask the nurse to protocolize that they actually turn off the sedation once a day at least, and if they require sedation again, to go only to half the prior dose, and thus ensure that they're on a minimum amount necessary for that patient. It's interesting to note, I think also, that in this trial, the control arm, which is shown here as usual care plus spontaneous breathing trial, they still got an attempt at ventilator liberation, and they still got some sedation weaning. In fact, 1/3 of the patients in this arm of the trial actually did have the sedation turned off, just as the intervention group did. However, the other 2/3, the nurse felt that it wasn't safe to do. And that just tells you that 2/3 of the time it may be safe to do when it appears to us as healthcare providers, and perhaps to our nurses, not to be potentially safe. And if you're worried about the potential risk, theoretical risk of endotracheal tube dislodgement from a sedation holiday, I think it's reassuring to know that the patients who did spontaneously dislodge their endotracheal tubes in the course of this trial had a similar rate of requiring reintubation to patients who had passed a breathing trial. And so this is something that's clearly worth spending a lot of energy working on, because it has a large effect size. It's something that applies to COVID-19 patients. Now, there are patients who don't, in whom it is not safe to lift sedation. Patients certainly who are in status epilepticus or seizing, or would have been excluded from this trial. Patients who are on extremely high ventilator settings. I think that's not the time to do this. But as soon as they are synchronous with the ventilator and get to the point where they would have met inclusion for Tim Gerard's paper here, I think, if you save 1 out of 7 of their lives, it's worth doing. A similar finding in 2000, the famous ARMA trial compared a tidal volume of 6 cc's per kilo ideal body weight to the more traditional higher tidal volumes of 12 used at that time, and found a survival benefit from that as well. And again, this is based 6 milliliters per kilogram of ideal body weight, which is based on a patient's height and theoretical lung size, not on their actual body weight. Well, what PEEP should I use is a common question, and certainly there's been a lot of controversy around this question for COVID-19. But the best available data suggests that it may not make a statistically significant difference on survival how much PEEP you use. It certainly seems at least reasonable to adhere to the ARDSNet table. That's one approach that could be used and is well established. Although there is an association with use of lower PEEP below this low PEEP table here shown, that there is an association with poorer outcomes. And so I would not recommend you go below what this low PEEP table shows. But within these ranges, it appears to be equivalent as long as you're otherwise targeting lung protective ventilator settings, including lower tidal volumes and targeting a plateau pressure of 30 centimeters of water or less. Another way to, at least it appears, to protect the lungs from ventilator-induced injury and perhaps render a benefit to them is by simply turning them onto their stomach. It's the way many of us sleep. And this more favorably redistributes the pressures of the ventilator. There are a number of other potential physiological mechanisms of this intervention, but it's a free intervention, although it does take considerable staff time and some protocols have to be written. But in this trial, the PROSEVA study in 2013 was shown to have a mortality benefit in the subset of ARDS patients who have a P to F ratio below 150 after ventilator optimization for a short period of time. And these criteria are met by about half of our COVID-19 patients. This is how it appears. It's simple in many ways, although again, you do have to establish a protocol so that the patients can be turned, pressure ulcers avoided, and tube and line dislodgement also avoided, and tangles avoided. Another factor that comes into play a lot with our COVID-19 patients, for which we have strong evidence, which really comes from actually a negative trial, the FACT study shown here, but but an important trial nonetheless that showed that it appears that patients with ARDS do better and get off the ventilator a few days faster, which is again important right now. If they are kept a bit on the dry side and aimed for a roughly net even volume status, as opposed to an average of 1 liter per day positive in the liberal arm of this study. The details on how they achieve this are probably not relevant anymore. This was done in part based on CVP and a number of other physiological metrics, PA catheter measurements, wedge pressures, which we don't necessarily use, but I think the principle still applies, and diuretics can be used once patients are out of shock on the basis of this trial. It did not appear to harm their renal function on average in this study, if that is a concern you have. So keeping patients on the even to dry side is good for ARDS patients. Now, ARDS patients also, COVID-19 patients, I should say, also get a lot of other routine critical illness problems. So, they get anemia from serial phlebotomy and from a number of other mechanisms, no doubt. And there is some data suggesting that a hemoglobin target of 7 is just as good, if not slightly better, to a hemoglobin target of 10. If anything, it appears to be better to target 7 than 10 in terms of a survival benefit among certain subsets of patients, the less severely ill and the younger. But overall, it reduces the number of blood transfusions required and doesn't seem to harm patients. Is this same approach appropriate if a patient is having upper GI bleed? Well, as long as you understand the exclusion criteria of the Villanueva study from New England Journal of 2013, which looked at this question comparing a hemoglobin of 7 to 9, as long as you understand that they did not really target a hemoglobin at all in exsanguinating patients and certain other exclusion criteria, you could see that if anything, there was a benefit in terms of survival to adhere to a restrictive strategy of a hemoglobin of 7 as opposed to 9, perhaps related to reductions in venous pressures and thus reductions in bleeding from targeting the more conservative hemoglobin level of 7. We've found that many of our COVID-19 patients, for one reason or another, do require vasopressor support. I think in part this is driven by a distributive physiology, although it's also very much exacerbated by medications we're using and peak pressures on the ventilator and other things. And there is some data supporting, the use of at least some vasopressors over others. And in the 2010 New England Journal paper by DeBacker, norepinephrine was shown to be have this non-significant trend toward improved survival over dopamine overall in all comers with shock. But also norepinephrine patients had fewer arrhythmias, seemed to be overall safer than dopamine. And in the subset of patients who had cardiogenic shock, which were actually thought a priori to be the group that was most likely to benefit from dopamine, that if anything, it appeared that dopamine was harmful to that group, so norepinephrine was better. Similarly, vasopressin can be safely used at 0.03 in units per minute to spare catecholamines, and again may have some benefit in a subset of less severe septic shock patients, and can be used in COVID-19 as well. With that, I will conclude. I think it's just important to remember that even when things are bad and when we're overwhelmed with patients, maybe especially when we have this many severely sick patients and we're out of our comfort zones, the motto of prima non nocere, no non-maleficence, first do no harm, remains important. If anything, it's more important now than ever. Try to avoid things and avoid spending your energy, which is valuable, on things that don't have evidence for them. That's fool's gold and will lead you away from the important things. There's enough work to do to focus on the evidence-based things, I think, in general. That isn't to say that we don't have work to do to learn new things that are important. And I think you're going to learn about some exciting things in this conference that are very important that I haven't mentioned. But I do want us to all remember, and I think unfortunately the outcomes we've had in the United States, which have been less than stellar, are a good reminder for me and for all of us to not ever neglect the fundamentals. COVID-19 patients, so even though it's a new disease, present with syndromes for which we really do have decades of research to inform our management. And so I think planning and focusing on the fundamentals helps us in these terrible times. And with that, I will stop. If I seem tired, I hope I've maintained your interest and given you something worthwhile to think about. In part, it is 4 a.m. my time, and in part, this young lady here hasn't let me sleep for a few months. And so I apologize if I have any sleepy in my voice. But I would love to take any questions if there's any time left.
Questions. I think is about your experience in giving plasma to the critically ill patient. That is something which is a lot of, even 2 questions having on that plasma therapy.
Excellent question. Convalescent plasma, I assume, is the meaning of plasma. Unfortunately, the largest studies of convalescent plasma done to date that I'm aware of have not rigorously addressed the question of effectiveness, but it is thought that convalescent plasma is safe. It's also accessible, and there is some suggestion of benefit in some analyses done by especially the Mayo Clinic's large study that came out recently. And so I think it is a reasonable thing to offer people. I would say that it would be best if you have access to a clinical trial to offer patients access to this to convalescent plasma under the auspices of a study, so that hopefully we could generate information that allows us to better assess whether we're spending our energy and money wisely using that intervention.
Well, there's one more question I think I'll put it, those people who don't have experience of prone ventilation, should they start with in this pandemic? Because a lot of physicians have never put patients on prone ventilation.
It's a great question. I would say that that may depend on your center and on the level of staff support that you have, which may vary from time to time too, depending on the status of the pandemic in your area. But there's no time like the present to go ahead and start training people, writing protocols to that end, so that you're prepared if, God forbid, you do have a large number of patients who would benefit from that procedure who could not otherwise get it. It has a large effect size, it appears, from the available literature. A number needed to treat of 6 to save a life of patients with the PDAF less than 150. I think that's worth a lot of work to say, that save that many lives. And so, and I'd be happy. I'm sure there are many protocols out there, but I'd be happy to share some of the ones. We had to write one ourselves and train our nurses at one of the institutions where I work at the VA Medical Center here in Birmingham, mid-pandemic, because we just decided this was too important to wait. But it's a good question, and I'm sure it isn't necessarily the right time for everybody. These are unusual times.
I think we can end this session now. Thank you, Derek, for spending your valuable time, and more than that, to be awake at that time, and that too not in the ICU for us. So,
My pleasure. Thank you very much for having me.
Thank you, Derek.
Yeah.
It was a wonderful session, and we have been something which is coming from the horse's mouth. So your experiences will be shared to all of us here, and they'll definitely help in treating our patient. Thank you very much. We can go to the next session now. Next session